عليكم. اليوم في عنا الانترا اورال اكزامينيشن. يعطي العافيه محمد اجا وهي ثالث مره بيجي عشان الديمو. We will start with the vermilion zone of the upper lip and the lower lip. This is the part that we see extraorally. We look at the vermilion, okay, for any finding, either developmental or pathological. We look at the vermilion border, which is the junction between the exposed part of the lip with the skin. Usually it is sharply demarcated. In elderly people or those people who are having sun damage, you will see that this border is not well defined. You need to pay attention to the junction of the vermilion zone with the skin of the upper lip, because usually, commonly we see Fordyce granules at the junction of the upper vermilion zone with the skin, or even the lower or corners of the mouth, but it is more common on the upper part. Okay. To examine the lower labial mucosa, we need to gently evert the lower lip, exposing the labial mucosal surface. In this patient, we see here a linear white, slightly exophytic lesion. In this case, it is most likely scar. Here it is. Okay, it's most likely scar from trauma of the upper central incisal edge. So mild, gentle eversion. You look for any developmental or variation of normal or lesions. Here you can see granular appearance and feeling of the lower labial mucosa. These are the minor salivary glands. Sometimes they get little enlarged because of the hot drinks or as reaction to thermal trauma or other types of trauma. Okay, so we evert the lower lip. We go all the way down to see the sulcus, but gently, don't over evert the lower lip so that you don't traumatize the labial frenum. Look all the way down to the sulcus to checking for any finding. Now the upper lip, the same way, you evert the upper lip gently. Okay, looking at the mucosa, at the junction of the vermilion with the mucosa, looking all the way to the corners of the mouth. Then you continue everting gently, not to tear the upper labial frenum. You look all the way to the depth of the sulcus. Okay, in this patient, I see gingival nodules. These whitish nodules on the attached gingiva in this patient, they are called gingival nodules. They can be collections of epithelial cells, keratinocytes that are not sloughed yet, but I don't see collections of materia alba or other or plaque or this whitish layer. So here, these are the gingival nodules in this patient. Read about it. Go and search about gingival nodules of the attached gingiva. Okay, so we looked all the way to the sulcus of the upper and the lower labial mucosa. We examined the corners of the mouth for any developmental or lesions. I start by examining the corners of the mouth before I go to the buccal mucosa, so that we don't cover it with the mirror and just ignore it while examining the buccal mucosa. Okay, now I look at the corners of the mouth, which is the junction of the upper lip and the lower lip, and I slightly evert. Here we see multiple pinpointed yellow dots. Okay, these are Fordyce granules, ectopic sebaceous glands. Okay, let me examine the other corner of the mouth. I don't see here. There are only few Fordyce granules, pinpointed yellowish spots. I see also more of yellowish granules at the junction of the upper vermilion zone with the oral mucosa. Pinpointed 1 millimeter in diameter yellowish spots. We will start with the buccal mucosa, starting from the corner of the mouth. We already examined the corner of the mouth. Now we will cover it with the mirror to retract. I will retract the buccal mucosa and examine it from the corner of the mouth to the pterygomandibular raphe. افتح محمد شوي. All the way to the pterygomandibular raphe, involving the retromolar area, and up, سكر شوي, and up to see the all the depth of the maxillary sulcus all the way posterior to the maxillary tuberosity. I'll go all the way down to see the depth of the mandibular sulcus from anterior to posterior. Now, what do we see on the buccal mucosa? In this patient, I see milky, diffuse, whitish appearance involving all of the buccal mucosa, and the whitish appearance disappears upon stretching. This is leukoedema. I see here a small horizontal white line at the occlusal plane. In this patient, it came close to the posterior molars here. This is linea alba. Linea alba is variable. You can see it extending to different extensions in different patients according to the occlusion. Okay, from the normal anatomy that we check while examining the buccal sulcus is the Stenson duct papilla. In Stenson duct papilla, I see the orifice of the Stenson duct. Usually it is of normal color, like similar to the surrounding mucosa. It's usually located opposite to the upper first molar. Okay, what else do we see in this patient? No more findings. I will do the same for the other side. After finishing the buccal mucosa, we go up to the palate. We will start examining the hard palate, starting by the anterior part, from the incisive papilla, the rugae area, and from the attached gingiva of the anterior teeth to the premolar and molar teeth, the attached gingiva, and then go all the way to the other side, examining the attached gingiva of the other side. In this patient, the color is normal and there is no any variation of normal. There is such as prominent maxillary raphe, such as a torus palatinus. We don't see these variations of normal. The incisive papilla is of normal color and size. It is not inflamed. Sometimes we see patients with inflamed incisive papilla due to trauma from food, from eating hard food, like apple or carrots. So you'll find their incisive papilla inflamed. Sometimes we find a burn. These are some of the common lesions we see, burn from pizza on the hard palate or the soft palate. Now, the anterior part of the palate appears relatively pale. There are several reasons for this related to the histology of the submucosa. If we go back, the posterior part of the hard palate on both sides, it is also looking pale because of the fatty tissue in the submucosa on the lateral aspect of the palate. In the posterior part of the palate, we see occasionally you can identify the orifices of minor salivary gland ducts. In this patient, they are not particularly prominent. In some patients who drink a lot of hot drinks or smokes due to the thermal injury, you will find the ducts of the minor salivary glands dilated and inflamed. Start with the soft palate, asking the patient to say ah. Look at the vibrate again. Look at the vibrating line between the soft and hard palate. Look at the soft palate. You see fine granules. These are minor salivary glands covering the soft palate. The soft palate also has a lot of lymphoid tissue in the submucosa. In some patients, you can find some nodular hyperplastic lymphoid tissue collections. They will be more prominent than these fine, slightly granular minor salivary glands. In this patient, again, please say ah. Look at the uvula. It is bifid in this patient. This is the mildest form of the cleft palate. Look at the inferior border of the uvula, how it has cleaved in this patient. I don't consider your examination complete of the soft palate and the oropharynx till you see the oropharyngeal wall. That is the posterior border of the oral cavity. Look all the way posterior behind the uvula. Look for any lesions, uncommon finding, unusual lesion like a nodule or enlargement or pathology. Look at both tonsils. In this patient, I consider his tonsils larger than normal, but according to the history that he had multiple recurrent tonsillitis while he was young, so this may be reactive lymphoid hyperplasia. Look at the palatoglossal arches, palatopharyngeal arches, anterior and behind the tonsils. Okay, so revise the anatomy of the oropharynx. For examination of the tongue, we need to have gauze and mirror. If I don't see the gauze on your tray, then I will understand that you did not examine the tongue completely. Okay, Muhammad, stick your tongue out, please. I hold the tongue gently, wrap it with the gauze. I look at the dorsum of the tongue. The normal anatomy here, I see filiform papillae mixed with fungiform papillae. The filiform is whiter than the fungiform. I take the tongue, طلعه أكتر, طلع لسانك أكتر. Examine all of the anterior 2/3 of the dorsum of the tongue. Posteriorly, you will see a V-shaped line composed of circumvallate papillae. You don't have to enforce the patient and press forcefully to see that line. Okay, you can examine only the anterior 2/3 of the tongue. Now, I hold the tip of the tongue again and take the tongue gently to the other side and retract the buccal mucosa with the mirror. I see all the lateral border of the tongue from the tip to the foliate papilla. Now, أيوة طلع لسان مرة ثانية. Here is the foliate papilla on the posterior lateral border of the tongue. It is a normal anatomy, it is not a lesion. Sometimes it is enlarged, more red than this, we can call it foliate papillitis. There are no lesions on the lateral border or the let's say the exposed ventral surface and the floor of the mouth. I will ask the patient now to kindly raise up your tongue to touch the palate. Okay, I will examine the inferior border of the tongue. I see these two ranine veins. They are located just lateral to the lingual frenum. This is the lingual frenum. Okay, at the junction of the lingual frenum with the floor of the mouth, you will see this papilla, lingual papilla, and it contains the orifice of Wharton's duct. Wharton's duct drains the saliva from submandibular salivary gland. While here you see a lateral fold, lateral lingual fold. This lateral lingual fold contains the ducts of the ducts openings of the sublingual salivary gland. On both sides of the lingual frenum and the ranine vein, you will see plica fimbriata. In this patient, it is not prominent, just a vertical fold of tissue that sometimes has tissue tags, moving or movable tissue tags. In this patient, they are not prominent. We have reached the maxilla and mandible alveolar processes for both upper and lower. محمد سكر. Okay, سكر لسانك على بعض الطواحين. I will look at the gingiva. I will examine the alveolar processes by inspection first. If I see any variation of normal, buccal exostosis, parulus, sinus tract, anything abnormal. So I examine both upper and lower gingiva. I write down my notes. You can examine the gingiva while examining the labial mucosa with the labial sulcus with the gingiva, or while examining the buccal mucosa with the buccal upper and lower sulcuses. You can also write your notes. But now when I examine it all together, I have more comprehensive picture. And even I can check like other findings of tooth structure changes while looking at the gingiva upper and lower together with the teeth occluded or coming in contact with each other. After inspection, I will do the palpation. افتح محمد. I will palpate the alveolar bone or alveolar process digitally without placing much pressure. Just palpate. I will ask the patient في ألم بأي مكان. I am paying attention to having elevations or swellings, and also the patient should tell me if he is having pain. I don't find any abnormality or variation of normal. I cannot consider myself finishing the gingiva without examining the retromolar pad area, okay, on both sides, and the maxillary tuberosity using a mirror. Okay, Muhammad, سكر شوي. Take your mandible to the other side, please. Here is the maxillary tuberosity of the left side. هلا جيب الماندبل للجهة هاي، أيوة lateral placement of the mandible وسكر شوي. Here is the maxillary tuberosity of the right side. Now, if you need to do the bimanual examination of the submandibular and sublingual salivary glands, we can do that by sliding our fingers of one hand lingual to the first and second mandibular molars, and your fingers of the other hand pressing from outside. You can now have the submandibular salivary glands in between your fingers. The same way I will do it for the other side. I slide my finger along the lingual surface of the posterior teeth and the other hand from outside, and I can feel the submandibular salivary gland in between my fingers. Here in this patient case, it is soft, homogeneous, semi-firm actually. It is not very soft like fluid filled, but it is homogeneous. I don't feel any nodules. I go more forward or more anteriorly and slide my fingers down to palpate the sublingual salivary gland. By pressing, I'm seeing the saliva actually leaking out from the on the lingual fold. Okay, by pressing, I see saliva, a lot of saliva is wetting the floor of the mouth. Now, this hand that I palpated the skin, I used to palpate the skin, I cannot put it back in the patient's mouth. When your gloves touch the skin of the patient, it's not advised to use it back to the intraoral examination. You will take the bacteria from the skin to the intraoral. By this, we conclude the intraoral examination.